Good morning, everyone. I am myself Dr. Yeshwanth from the Department of Oral and Maxillofacial Surgery, here to present a topic on management of impacted teeth. Impacted teeth, by the definition, is completely or partially unerupted and is positioned against another tooth, bone or soft tissue, so that its further eruption is unlikely, described according to its anatomical position. So these are the type of other teeth. Here Malpose teeth are erupted, but they are in abnormal position, and in unerupted teeth that they are not erupted into the oral cavity. And ectopic displaced teeth, these are type of the teeth which are erupted other than its normal position, or they can be also known as aberrant teeth. And next comes this is the order of frequency, starting from the maxillary third molars. These are the most common impacted teeth, followed by mandibular third molars, maxillary cuspids or premolars, mandibular bicuspids, mandibular cuspids, maxillary bicuspids, and lastly maxillary lateral incisors. And lateral incisors are also most common ectopic erupted teeth. And these are the following theories, and these are the only theories, these are only hypotheses, these are theories that are not proven. And first comes is Mendelian theory. Here, as you know that according to Mendelian theory, evolutionary reduction in size of maxilla or mandible can lead to impaction of the disease because of decrease in the amount of the jaw. And also phylogenetic theory, here it states that changing of masticatory habits, it leads to elimination of stimulus. Like we can correlate with that usage of organs will increase the amount of usage, and but here the masticatory habits that nowadays we are eating soft food, so this related to the elimination of the teeth, which decreases the size of jaw, therefore the teeth results in impaction of the tooth. And orthodontic theory, here it states that the loss of anterior component of force leads to impaction of the teeth. And endocrine imbalance theory, due to a hormonal imbalance, impaction can cause. And pathological theory, due to presence of any cysts or tumors, the dental follicle will not give rise to the teeth. So the etiology may be systemic. In that first one, prenatal, that is before birth, due to hereditary or misconjugation of the teeth, impaction can be result. And postnatal causes, that is after birth, these are diseases like rickets due to the deficiency of vitamin D, anemia due to deficiency of hemoglobin, congenital syphilis, tuberculosis, endocrine dysfunctions and malnutrition can result in impaction of the tooth. And rare causes are cleidocranial dysostosis. This is a dysostosis which results in impaction of the tooth. And oxycephaly, that patient will have pointed hair, and keratosynostosis. Keratosynostosis is the premature fusion of the sutures before its normal time. And progeria is premature old age, that patient look old even patient doesn't have that much age. And achondroplasia and cleft palate. Cleft palate is the most common head and neck congenital disease, which can result in impaction of the tooth due to the malunion of the muscles present in the palate. And these are the local factors which include irregular adjacent teeth, increasing density of the surrounding bone, long-standing chronic inflammation, and premature loss of primary dentition can result in the impaction of the teeth. And these are the indications for which we should remove the impacted teeth. The first one is pericoronitis and recurrent infection. This is the most commonest cause of the impacted teeth. And unrestorable caries, usually the teeth which are impacted, that is any aids or any canines which cannot be restored with the help of any dental cements or any root canal treatment, they must be removed surgically. And periodontal disease, like formation of periodontal pocket and recession of the teeth, so these results in great management of the removal of the teeth. And development of cystine tumors which results in deflection of the teeth and this results in removal of the teeth. And orthodontic reasons, damaging adjacent tooth, neuralgic pain or trigeminal neural paresthesia in the region of the third molar teeth. Orthognathic surgery, like especially in bilateral sagittal suite osteotomies, third molar should be removed 6 months prior to the operation. Prophylactic removal of the teeth. Tooth in the line of fracture, especially in the angle fractures, tooth in the line of fracture should be removed, as it compromises the healing of the fracture and also the union of the fracture fragments. And prosthetic reasons for the placement of any crown placement or any complete denture placement, third molar impaction can result in difficulty in placing that prosthesis. So people are advised to remove this teeth surgically. And autovenous implantation, suppose if first molar or second molar is lost due to any reasons, third molars are extracted and transplanted into that socket. And trauma to soft tissue can also result in the surgical removal of the tooth. And these are the type of setting. Here you can see in the first image, the operculum is inflamed. So as a result, we should remove the teeth. And here is a clinical image where the operculum is inflamed, so that we should remove the impacted tooth. And here you can see that the proximal caries of 7 is due to the impacted of the mandibular third molar. So here in these cases, and also here you can see that there is formation of caries here. So this is the indication for the removal of the teeth. And here in this case you can observe the teeth is impacted, and here there is a pathological cavity surrounding in the region of 6 and 7. And here you can see there is a large cyst formation extending from first molar teeth all the way to the sigmoid notch. And here you can see that the teeth is impacted, which is present at the lower border. And also here we can see that it is a pathological condition where the seventh or second molar is present deep to the first molar. So for this we should remove the third molar so that the second molar will come into its original place. And also the contraindications like health and age consideration, too young and too old age people are considered as contraindicated here for the removal of the third molar for obvious health reasons and prosthetic reasons, availability of adequate space, and socio-economic causes. And the common complications from arising the retained impacted teeth are persistent local infection. If we don't remove the impacted teeth, even if there is acute or chronic inflammation, it can result into acute chronic alveolar or abscess from pericornitis diseases, and also chronic suppurative osteitis that can be osteomyelitis results, and necrosis of the bone can also form, and finally it can lead to osteomyelitis. So if there is a cyst or tumor present in relation to third molar teeth, if we don't remove that teeth, the resorption of the adjacent teeth or especially roots can happen, and pathological conditions like cyst and tumors can grow aggressively, and facial pain of unknown origin, it can also occur due to the retained impacted teeth, and also fractures of the jaws due to weak spots. And these are the classification of impacted molar. For our convenience, we are classified according to the nature of overlying tissue, Winter's classification, Pelle and Gregory classification, Clay's classification. Here the impaction can be occurred because of one hard tissue and second one is soft tissue. And Winter's classification is based on the inclination of third molar to the long axis of second molar. Here you can see that the type of impaction. Here in first case, the vertical impaction, the long axis is vertical to the second molar, that is they almost lie in same plane. And in mesoangular impaction, the crown is towards the second molar and roots are diverged. So these are in horizontal impaction, the almost the crown is horizontal to the second molar, that is the long axis of the third molar is horizontal to the long axis of the second molar. And in distoangular impaction, contrary to mesoangular, here the roots are towards the second molar and crown is away from the second molar. And in Pelle and Gregory classification, in the first one is the class, that is relation of tooth to the ramus of the mandible and the second molar. Here you can observe that there is sufficient amount of space is present for the eruption of the third molar, that is class 1. And here the half of the tooth is present in the ramus, and in class 3 the entire tooth is present in the bone or totally in the ramus. Here class 2 or class 3 are considered as a difficult one to remove, and whereas class 3 is the most difficult one for surgical removal of the third molars. And it is the Pelle and Gregory classified the impact teeth according to position. Here in position A, the third molar is present almost equal to the second molar. In position B, it is present below the occlusal level. In position C, here it is present below the CJ, that is cemento-enamel junction. So according to Pelle and Gregory, position B and position C third molars are considered as the most difficult to remove, and in that position C, which is present entirely in the bone and also below the CJ, is considered as the most difficult for the measurement of third molars. And C is based on inclination of the third molar to the long axis of second molar, that is based on the Winter classification which we have discussed before. And Clay's classification is in A, based on inclination, that is Winter's classification, and based on stage whether it is erupted, partially erupted or unerupted, and number and pattern of the roots, that fused roots are maybe present, 2 roots, multiple roots, these can be present. Here you can see that in first one it is mesoangular classification because the crown is towards the second molar teeth, and then this entire classification is based on Winters classification. Here in the last one you can also notice that teeth is inverted, that is crown is facing towards the roots and roots are facing towards crown. And position A and position class 1 are based on the presence of depth and relation to the third molar. So for the extraction of the surgical extraction of third molars, we should examine general examination, local examination. In general examination we should include all the necessary investigations. If patient is having any comorbidities like hypertension or diabetes or any blood related diseases, and local examination includes clinical and radiological. In general examination, the age is considered. Here younger patient, the surgery is easy and it causes less morbidity, whereas in old age it is difficult and has greater morbidity. Medical status. The medical status of the status is very much important, considering that it is a surgery which includes the loss of blood. So patient who is on antiplatelet drugs or anticoagulation drugs, the INR and APDT should be considered before performing any surgery. In facial form, if patient is having tapering type of form, here surgery is easy, and if it is having square and compact form, it is difficult to perform surgery. In clinical examination, we should consider the eruption status, that tooth is erupted or unerupted. In local infection, if it is acute or chronic. So if the tooth is having acute infection and there is presence of any space infection, patient would be on loading dose, and we should perform the surgical extraction only when patient is having sufficient amount of antibiotic dosage. In periodontal stages of the teeth, adjacent teeth, the tongue, that is macrogloss or microglossia, can be considered, and mouth opening is an important one here. The mouth opening which may be less because of trismus or any space infections, it can result in difficulty in extraction of third molars. And occlusion relationship with the upper arch. External oblique ridge, presence of external oblique ridge will cause difficulty, because we should remove some amount of external oblique ridge for the access and visualization of the third molar. And mandibular protrusion or retrusion. Regional lymph nodes can be palpable in cases of any chronic infections like tuberculosis or leprosy cases. And in TMJ, the moment of TMJ should be considered, that is any clicking source are present or any dislocations or any internal derailment is present, which can result in difficulty in extraction of third molars. And radiological examination, here occlusal view and orthopantomograph are important one. On periapical view, if there is no availability of OPG, here they can use periapical radiograph, and retrooblique can also be considered. Here in this, we should for the radiograph we should interpret the axis, position, difficulty, that is Warface assessment, and crown and roots of impacted teeth, bony texture, existing pathology, and position and root pattern of second molar, and relationship with inferior alveolar canal. Here the presence of vertical oblique external ridge results in poor access, and horizontal external oblique can be good access. And there is a ridge is behind the tooth, it can result in good access, but if it is present in front of the teeth, as in class 2 or position B, the poor access can be happen. And here you can notice that the teeth, the external oblique ridge is almost present entirely in the ramus region. So here it causes the difficulty in extracting of the teeth. Here you can see that there is the inferior alveolar canal is almost in the CEJ position. So it can result in bleeding or paresthesia of the IANB nerve. And position and depth can be considered by using George Winter lines, that is white line, amber line, and red line. Here we should draw 3 lines. Here the first line is the white line. Here it is drawn according to the actual level of the teeth. And second line is the long axis should be drawn in second molar and third molar region, so that we can identify the type of impaction. And in the amber line, it shows the amount of the bone that should be removed. Here you can notice the bone distal. Here you can see a red line that is drawn from the CEJ of the line. Here in the third molar is present below the CEJ, so it is considered difficult. Here this is an periapical radiograph. Here you can see the lines are drawn here. The first line is drawn at the occlusal level, second line is drawn at the CEJ of the second molar and third molar, and the X is marked, that is red line. It is a place where we should place the elevator for the extraction of the tooth. It is common for all type of teeth except distoangular. In distoangular cases, the red line will be in distal position, so we should place our elevator in the distal position for the removal of the tooth. Here, this is a distoangular impaction. Here the roots are near than the crown. This is the red line, the perpendicular line which is drawn below the amber line. So it notices the amount, the the place where we should keep the elevator for the elevation of the tooth. And Warface assessment is based on first Winter classification. Here horizontal classification, classified molar is given highest degree, that is 2, and vertical is least. Height of mandible, it depends on the mm, that is 1 to 39 mm. Angulation of the third molar, that 1 to 90 degrees. And shape of the root, that is complex root, have 1 score and unfavorable curvature of 3 score. Follicle, the presence of follicle will have will have effect on the surgical removal of molar, that is enlarged follicle will have 2 score. And path of exit, the space is available, it is considered 0, and both mesial cusp and distal cusp are covered. It is 3. So the highest score we can give is 33 in Warface assessment score. Greater the index, greater the difficulty, and is a difficulty index is based on the Winter's classification, Pell and Gregori's classification. So the final interpretation is minimally difficult, the score is 3 to 4, and very difficulty, the score is from 7 to 10. And these are the pattern of that. Here length, fusion, curvature, width and position of the second molar can result in assessment of the impaction of the third molars. And relationship to the canal, here you can notice that there is darkening of the root. Here the roots are darkened, you can notice here, and deflection of the root, the roots are deflected as in destroying layer impaction, and narrowing of the root, the roots are narrowed because of presence of infraalveolar canal, and dark and bifid apex. Here only 2 apex can be seen because of the darkening of the roots. And here we can see the relationship third molar to the inferior dental canal as in radiographs. Here root lightly notched in A radiograph, and B it is apical notch is present, that is notch present in apical region, and in C it is like deeply notching, that the canal is through and through from the tooth, and the canal perforates the tooth in deep position. Here these are the type of the classification according to the canals. Here there is interruption of the white line. Here you can see the line is interrupted because of presence of the tooth, and there is narrowing of the canal because the roots are perforated into the canal, and there is diversion of the canal because of the diversion of the roots. And in cross section view, here the separate canals are considered, their radiograph they will appear like this, and in grooved, because of presence of root inside the canal, the radiograph will appear that the root is present inside the canal. In perforated canal, the root is present through and through from the canal. So these are the here you can notice that there is canal present here in cross sectional views, and these are the type of the inferior alveolar interpretation. And pericornate is the most commonest cause for the removal of that root. Here you can see that there is a operculum is inflamed in diagram A, and B is a clinical image. Here you can see that the gingiva is inflamed in relation to the third molar here. And the predisposing factors include lower tissue resistance, upper respiratory tract infection, emotional stress, fatigue and pregnancy. And classification can be, first the infection starts from acute stage, can results in the subacute stage, and it progresses into chronic stage. In acute stage, the pain will be severe throbbing type, and there will be extraoral swelling, limitation of mouth opening, lymph nodes can be enlarged, and rising temperature, and gum pad may be swollen tender, and there may be a discharge of pus from the flap. So here these are the spaces where the pericorneal third molar can result in. Here submasseteric space, sublingual space, submandibular space are the most common space. So these are according to the mylohyoid line. Infection is spreading from the roots towards the buccal region, and here these are the roots of spread. Here you can notice the masticatory space is present on the top, and little pharyngeal space and buccal space is present based on the buccinator muscle, and mylohyoid line is considered here. Above the mylohyoid line is sublingual space, below the mylohyoid line is considered as submandibular space infection. And the management can be conservative, surgical removal of overlying flap, and surgical removal of the teeth. And in conservative treatment, you can use the irrigation with warm saline or medicated solutions. Antibiotics and drainage of the abscess is the most important one. And in surgical removal of the flap, here you can use blade, electrosurgical scalpel, radiosurgical loop, and nowadays laser can be used, so that the access can be easy and the no blade can be pulled in that area. Here in some of the cases we can suture the entire flap and we can remove with one go. And in surgical removal of the teeth, here these are the preoperative checklist you should consider for removal of the tooth, and also the Warface assessment should be considered, and Pedersen score can be given for the assessment of the teeth. Here anesthesia can be used as local anesthesia, and if red line is greater than 5 mm, general anesthesia is considered. Here the incision can be started from mucoperiosteal flap, so particularly the design should be such that our teeth should be have adequate visibility and access. And here the triangular flap can be given for the, here the tooth is entirely in the bone, so that the triangular flap can give good access. And modified Warts incision, here the incision starts from the first molar and proceeds towards around the cervical region of second molar and towards the external oblique ridge. This type of incision is particularly useful for the horizontal type of impaction of the tooth. And also here involved flap is considered, so the incision starts from the around CEJ of the first molar, second molar, and proceeds towards the external oblique ridge. And Warts incision, here a modified Wart starts from the first molar and Warts incision starts from the second molar. And the elevation of the flap is the next step. And here the bone removal is done. It can be done with the help of chisel, burr, and combination. And here the Moore and Gilbert collarbone removal technique is used under the copious amount of saline irrigation, so that it cannot result in thermal necrosis. Now next step is here we should apply our elevator where red line is pointed and extraction is done. And there is a combination of the technique. Here in the buccal cortical bone is removed by stampage bone technique, and removal of the tooth can be done. There is sufficient amount of the space for the extraction of the tooth, and splitting can be done if there is a large amount of bone should be removed, and operation time is reduced, and risk of jaw fracture also reduced. So here this in single root teeth there is no need for sectioning of the tooth, but in roots with mesial curvature and sprayed roots, there is the tooth sectioning can be done, so that we can remove the tooth easily. Here the bone, first the bone removal is done, that is the bone which is covered here is the distal cusp, and afterwards crown removal is done, and the tooth sectioning is done, and two roots are removed. Here is the example where the tooth is present in the occlusal plane, so that in the C step where the tooth is sectioned and the tooth is broken with the help of Copeland's elevator, and both roots are removed. Here where there is present of single root, the distal cusp should be removed with the help of tooth sectioning, and remaining amount of the tooth can be removed easily, because by removal of the distal cusp there is a sufficient amount of space. And wood deployment and growth, these are the important steps after the removal of the teeth, so that the patient will come uneventful healing. And later definition is another technique with the by Boulder and Henry. Here incision is given in the same incisions, and also the stampage bone technique by remove the buccal cortical bone, and sutures are placed. In lingual spool bone technique, it is given by Sir William Kelsey Fry. Here the incision is a normal incision which is given for every incision here, but the bone is removed in the lingual form. First the vertical stub is done and horizontal cut is given, afterward distal cut is given, and both the distal and buccal bone is removed, and the removal of lingual bone. Afterwards the tooth is removed, followed by closure of the wound. And next, impacted maxillary third molar. Thank you.